Today I'm going to record about weight loss medications and ask the question whether they're of any value. This is the first time I'm doing it in which I am actually recording a talk before I'm presenting it to my patients. I'd like to talk about weight loss drugs into two separate categories. The majority of time I'm going to spend on GLP-1 agonists. But before I get there, I want to get a brief history of fat absorption blocking drugs, sympathomimetics that are combined with medicines to help the sympathomimetics, and medicines that alter brain reward pathways. So the field of weight loss medicines is quite strong, and the investigation has been pretty robust. The one I'd like to talk about is the one that prevents absorption of fat, and it started out as Xenical, but now it's called Orlistat, and the form that is available over the counter is llie. So on this panel is normal fat absorption. Fat is getting into the gut, the duodenum. The pancreas puts out pancreatic lipases. It breaks down the fat into smaller particles. Triglycerides gets broken into fatty acids and glycerol, and it gets absorbed. On the other hand, when you use Orlistat, it blocks the pancreatic enzyme. And when the pancreatic lipases are blocked, the fat globules are not broken down, and they get eliminated in the feces unchanged, and that creates fat malabsorption. So this was investigated in a study, about 1,600 patients in each group. It was a pretty robust study. This is the baseline characteristics of these patients. Predominantly, it was a good division between male and female, 55 versus 45. The weight was a little on the high side, about 110 kilograms. Body mass index was 37. And pre-diabetes was present in about 21%. The weight loss at the end of 208 weeks was impressive. It went up as high as about 11%, but by the end of 208 weeks, it was roughly around 7%. And mind you, this was not just the use of pancreatic lipase blocker or Orlistat, but it was also lifestyle intervention along with it. Not only did the weight go down, but in these patients, there was impressive drop in blood pressures. Okay. There was a reduction in triglycerides, which was quite impressive, as well as a reduction in fasting insulin at 1 year and 4 years. So there was some health improvement as well. So there was drop in blood pressure, drop in glucose, and drop in insulin. What did you have to pay for it? You had to pay for it by stomach growling, because fat would not be digested. It would get attacked by bacteria, and it would create gas. This was a pretty distressing side effect. You would sometimes get urges and uncontrollable elimination of feces, which would be full of fat. So this is a pan that is covered with fat. It's called fatty or oily diarrhea, and you would even have accidents. Now, when fat does not get absorbed and remains in the gut, the fat binds to calcium in our food. And when there is calcium that is bound to the fat, it is not available to bind to the oxalates. The oxalates are present in the leaves and leafy green vegetables. And because calcium is not available to bind the oxalates get absorbed into the bloodstream. And when the oxalates increase in the bloodstream, you get stones. You get calcium oxalate stones, and they get deposited in the kidneys cause calcific injury to the kidneys and kidney stones. So there is an increase in kidney stones when you use medications like Orlistat. Finally, when you use Orlistat, you don't absorb fat-soluble vitamins like A, D, E, and K, as well as beta-carotene. Especially vitamin D is not absorbed, and you're not able to supplement them effectively because in order to absorb these vitamins, you need fat with that. So fat-soluble vitamins are not absorbed well if you take them on an empty stomach. Certain drug levels are affected. Warfarin, which is a common blood thinner, needs to be used in lower doses. So perhaps the use of medication that blocks fat absorption is not that valuable. But there has been another medicine on the market which is called Qsymia. And this is a combination of a sympathomimetic called Phentermine as well as Topiramate, which is an anticonvulsant. So what does this do? A sympathomimetic is one that increases your blood pressure, increases your heart rate. It makes you more aroused. It's like you're having a fight or flight response. A cousin of a sympathomimetic like Phentermine would be speed or crystal meth, which we will all agree are bad drugs. Fortunately, Phentermine is a less potent version of this. But on a lower scale, it does more or less the same thing that crystal meth would do. Now that's combined with Topiramate, which is an anticonvulsant. It's a downer. It's a medicine that is very similar to Xanax or Valium. So I think this combination was thought of because on one hand, you want to increase metabolism and arousal, and on the other hand, you want to have a downer so that you don't have the brain side effects of being on a medicine that promotes arousal to a large degree. So this was evaluated, the combination of Phentermine and Topiramate was evaluated in the Conquer trial. About 1,000 in the placebo group, about 1,000 in the high-dose Phentermine Topiramate group, and about 500 in the low-dose group. Predominantly women, young people, body mass index of 37, which meant that on an average, they were about 75 pounds over their ideal body weight. So the outcome in the Conquer trial was impressive. Over a period of 56 weeks, which is roughly about over a year, the drop in weight was an impressive 13% with the high dose group, roughly 10% with the low dose group. Now, not only was there a drop in weight, but because you're losing weight, you're eating less and perhaps more physically active. The blood pressure went down, both systolic and diastolic. The triglycerides, which is fat in blood, had an impressive reduction. The HDL was impressively increased. Because you're eating less, fasting sugar went down, as did your hemoglobin A1C, and all of these were significant. And finally, you had lower insulin because you had insulin sensitivity, which is a good thing. Now, Qsymia or Phentermine Topiramate combination is contraindicated in pregnancy. And also clinicians who use a medicine that is potentially dangerous are advised to go through risk evaluation and mitigation strategy. And this is not a medicine that I am willing to prescribe at this point. Now, what were the side effects? Dry mouth, paresthesias, and constipations were significantly higher in the Phentermine Topiramate group. But in addition to that, there were a couple of things that were quite disturbing. One was that there was disturbance in attention span. It was 1 versus 4% in the high dose group. There was increased irritability, less than 1% versus 3%. Both of these were quite significant, as well as anxiety. So perhaps this medicine is not what it pans out to be, and no wonder a very few number of practitioners prescribe it. Now we move on to the third category, which is a combination of bupropion and naltrexone. So we talk about bupropion first. It is an antidepressant medicine that blocks the reuptake of dopamine and noradrenaline. So dopamine is a feel-good hormone. The norepinephrine or noradrenaline is a neurotransmitter, is the fight-or-flight hormone that promotes arousal. So this medicine is likely to increase arousal to some degree, and it's combined with naltrexone. So in order to understand how naltrexone works, we have to understand the neurobiology, or how our brain perceives motivation and reward. So we have a hedonic pleasure-seeking center that is under the control of the dopamine neurons. And in anticipation of highly palatable food or thoughts of food, this hedonic drive center releases dopamine, which goes and acts on the hedonic gratification center that drives the motivation and learning and drives the ability for us to obtain gratification from consuming the highly palatable food. What naltrexone does is that it blocks the release of dopamine in the pleasure centers. So it takes away the anticipation, it takes away the reward that you are going to get from food, and so you're unlikely to consume it. Now, before we think that this is all good, one should understand that researchers have made dopamine deficient mice. These mice don't release dopamine in our brain centers that drive motivation and reward-seeking behavior. And it is the smaller of the two mice out there. This mice is less active, it does not seek food, it dies of malnutrition. So having the drive to seek reward is a necessary aspect of happy living, and perhaps it's necessary to curb it in order to lose weight. And so this study tried that. This drug is called Contrave, and again, these were young people. They were predominantly women, perhaps because they didn't want to take the risk of any cardiac side effects. The body mass index was again about 37. And again, the weight loss with Contrave over 56 weeks was impressive. It was roughly about 9% in the high dose group and roughly around 7% in the low dose group. Now, there was a higher risk of getting nauseated, having headaches and constipation, and there was a slightly higher risk of having psychiatric adverse effects. Now, what we found again is just simply in terms of what you had to pay was there was an increased risks of nausea, headache, and constipation. Now, as this drug was released, there was a lot of talk on the market of two drugs that were discontinued. One was Meridia, which was a compound that was similar to bupropion, and the other was fenfluramine or Fentanyl. So the FDA mandated the company to do a safety trial to assess cardiovascular safety of this drug. So when you're doing a safety trial, you evaluate the safety after 25% of patients are recruited, after 50% of patients are recruited. And when the data at the end of 25 and 50% was released in terms of the analysis to the public, the manufacturer decided to stop the trial. At that time, the gastrointestinal, the stomach and bowel-related side effects were higher. Brain-related symptoms were higher. So we will never know the cardiovascular safety profile of this drug because it was never completed, and perhaps that's another drug that I would be willing not to consider. So I just wasted about 15 minutes of your time trying to give you information about these drugs. But what I really wanted to do was to talk to you about this group of drugs that I am willing to consider prescribing to you in certain select situations after I have evaluated you carefully. And these are drugs that are incretin analogs or incretin-like drugs. So what are incretins? There are two incretins. So just bear with me for a little while and just kind of look at their names. It's a very interesting story. The first one is called glucose-dependent insulinotropic peptide. So glucose-dependent insulinotropic peptide, we'll just call it GIP for now, and from now onwards to make it easier. The other one is called GLP or glucagon-like peptide 1. So what do they do? So as you're eating food, the body has to sense the arrival of food to get prepared to digest the food, to dispose of the blood sugar. So in order for it to do that and anticipate before the sugar actually hits the bloodstream, our gut, our duodenum, which is after the stomach, has receptors that recognize the entry of glucose or carbohydrates. And these special cells release a hormone which is called GIP, which then goes and tells the pancreas that this person has eaten a large meal high in sugar and carbs, be ready to pour out insulin. We'll discuss GLP a little bit later. So if I take myself and start giving myself glucose in the vein, mainline it into my arm, my sugar levels will start going up. And if I give the amount of glucose just to keep my sugar levels along this line, as you see, in other words, I am titrating the amount of glucose I'm giving to increase my blood sugar to this level. Would it surprise you to know that our pancreas is not used to seeing sugar in our bloodstream coming from the IV and recognize that a glucose load is coming and increase insulin levels? Because the response of the pancreas to increasing sugar levels is relatively slow. And as you can see, the bottom panel is insulin levels. The insulin levels when I mainline glucose does not go up. On the other hand, if I consume glucose by mouth, in other words, I'm just eating 50 grams of a sugary solution, my glucose levels in bloodstream go up, but this is recognized by these K cells that I've eaten sugar. It gives a signal to my special K cells that are making GIP, and as GIP is released, even before the sugar hits the bloodstream, the pancreas is ready to augment its insulin production, and insulin production goes up dramatically. So in other words, the connections between our gut and our metabolic organs that control our sugar is so precise that the pancreas knows even before the sugar hits the bloodstream that a sugar load is coming and how much is coming through the mediation of GIP. Now, what is GLP? GLP is designed so that the body knows when it should stop eating, because you have taken in nutrients and at some point you have to stop eating, and the signal has to go to the person saying that, hey, you've eaten too many carbs, you have eaten too much food, and you need to stop eating now, before it is too late. So that is the function of GLP. The GLP is more downstream in the small intestines, and as GLP is released, it is telling the pancreas. So GLP is the later phase in food digestion, and as GLP is released, it's telling the pancreas two things. Hey, get ready, you might need to secrete a little bit more insulin because this person, as expected, has eaten a little too much. In addition to that, it has to shut down glucagon production. Now, so in other words, as GLP-1 is released, glucagon, which is also released by the pancreas, gets shut down. And we got to figure out why glucagon gets shut down. So in other words, the combined effect of GIP and GLP is to go and tell the pancreas, the GIP tells increase insulin much more dramatically, and the GLP tells you to drop the glucagon levels. So why should one drop glucagon levels? So glucagon is a hormone that is elaborated when you're fasting. The reason it's elaborated is because we need a constant output of sugar to feed our brain. And the glucagon tells the liver, hey, release your stored glycogen as glucose. And if that's not enough, it burns the muscles, it breaks down the muscles and converts the amino acids of the muscles into glucose. Or it'll take the glycerol from fat release, fatty acid release. Triglycerides are released into fatty acids and glycerol. And the glycerol is taken up and glucagon converts it into glucose so that we can feed the brain. But it is necessary to shut down the glucagon after you have eaten because a large meal is coming in and the liver should go into storage mode and not output mode in which it's pouring out glucose. If glucagon is not shut down, the glucose levels will rise even higher. And that is one of the problems with diabetes and obesity and insulin resistance, in which the signals are not properly interpreted by the body. And the liver, instead of shutting down glucose production, continues to produce glucose in the midst of plenty. So GLP is important because it reduces gastric emptying. It tells the person, hey, you've eaten too much. You need to slow down. And when you have a stomach full, you would say, hey, should I take another bite? It tells the pancreas to stop glucagon production, increase insulin production so that the glucose that has been eaten can be disposed of. Tells the liver to stop making glucose. It stores fat in the fat cells. And it has receptors. We have receptors in the brain for the glucagon-like peptide or GLP-1 that improve satiety and reduce hunger. So what does GLP-1 and to some extent GIP do? GLP slows gastric emptying. It releases insulin. It drops glucagon. It stops liver sugar output. So the combined result of this is that the blood sugar drops, and if you look over a period of time, A1C will drop. It'll go and tell the brain to improve satiety and reduce hunger. So if you look at native GLP that our body is making, our body makes only about GLP that will last only a couple of minutes. So GLP-1 in native form, which is about a 29 amino acid peptide, small, once it is released, it is cleaved by an enzyme, which is called DPP4, and it inactivates it within 2 minutes. Now, GLP does a lot of good things, and it was not something that escaped the pharmaceutical industry, and the pharmaceutical industry wanted to capitalize on its benefit, but wanted to make it last longer. So Novo Nordisk, which is the maker of Victoza or Saxenda, Liraglutide, this is the same GLP molecule, but with some modifications. One modification is that lysine residue has a fatty acid attached to it. When you have a fatty acid attached to it, this analog binds to serum albumin. And when it binds to serum albumin, it delays the degradation of it. It prolongs the half-life so that instead of lasting 2 minutes, this can be given once a day and will have a 24-hour pharmacologically active lifespan. But injecting something once a day is a little cumbersome. The pharmaceutical industry obviously can do better. So they made Ozempic, or semaglutide, or Wegovy as it is called now, as a weight loss drug. It's the same GLP molecule, but with a modification in position 8, in which alanine is substituted by a fake amino acid so that it's not recognized by the peptidase that causes degradation. There's a spacer and a little longer fatty acids for more robust binding to serum albumin. And there is another modification at position 34 so that the fatty acid doesn't bind to the wrong region. The result of this is that this lasts for about 1 week. So this can be given once a week. Now these drugs have been around since 2005, and a number of them are available, and I have listed them out here, from Ozempic, Wegovy, which is the weight loss version of Ozempic, Victoza, which is the diabetic version of Liraglutide, Saxenda, which is the weight loss version of Liraglutide, which you take once a day. Mounjaro is a special one, which is a combination of both GIP agonist and GLP-1 agonist. So in other words, it combines the actions of both of these hormones that we make in our small intestines. There is one orally available drug which is called Rybelsus, which is an oral version of semaglutide. It is not yet available for weight loss. So let's see how these drugs are useful in helping you lose weight. So the first study that I want to point out to you is a study done with semaglutide to evaluate gastric emptying. So if you delay gastric emptying, if you slow down gastric emptying, the person will eat less. So in this study, gastric emptying was slowed down in the first hour. Overall gastric emptying was the same. And perhaps that's one of the ways in which this drug works. Now, when you slow down gastric emptying, you can improve satiety because you're full. You'd say, hey, I'm satiated, I want to eat less. So satiation is improved. Fullness is better. When you're full, the idea of consuming food is a little further away from your mind, so prospective food consumption was less. Hunger was less with these drugs. And in this study, when people were asked, how often do you have food cravings? How difficult is it for you to control your eating? How often have you given in to an urge to eat? How hungry have you felt? How often do you have craving for savory food? All of these were less compared to the placebo group. Semaglutide improved all of that. It also made you feel more fuller after a meal, so you tended to eat less. The one thing that did not improve, that did not go in the right direction, is that food is pleasure. When you eat food, you derive pleasure from it. Because you're blocking the brain centers, which I will explain to you later, that give you anticipation and reward from eating a food, the individuals who were on semaglutide had less pleasure from eating their meals. Did eating less, having satiation and less hunger translate into some better outcomes? And yes, it did. When semaglutide was given, blood sugar levels were less after a meal. You needed less insulin. Less glucagon was made, so less glucagon after a meal is good because your blood sugars don't rise as much. You had lower amounts of fat in bloodstream, triglycerides were lower. When you absorb the fat, you absorb them as chylomicrons. From the gut, fat is absorbed as chylomicrons. Because you eat less and your gastric emptying is slowed, the chylomicrons were less. Now moving on, I want to explore whether all of these translate into actually eating less calories. So this is the study that looked at that. Whether semaglutide at that dose per week reduced energy intake. So small number of patients because it's a study that is looking at mechanistic factors, younger group, predominantly male, which is a little surprising because most of this studies are done in females. BMI was in the mid-30s. So these people were roughly about 75 pounds over their ideal body weight. Now, I'm putting this slide up to tell you that when you start Ozempic, you don't start at 2.4 milligrams. It's a dose escalation for your body to get used to it. So you start at 0.25 milligrams per week for 4 weeks, then increase it to 0.5 and 1 and 1.7, and it's only in the 5th week that you will get to 2.4. So it takes 5 weeks, or at the end of 4 weeks is when you are at 2.4. And in this study, they evaluated energy intake. So I'm not going to go into all of these different things. I just want to see how much energy they ate less. And what you found is that there was an impressive 35% reduction in caloric intake. What that translated into is roughly an impressive 940 kilocalories less, almost 1,000 calories less by taking this drug. Imagine that you're eating 1,000 calories less per day by using these drugs. Now, I told you that these drugs not only act on your stomach and your pancreas, but they also have effect on the brain. So they go and tell the brain reward centers that you're not hungry, that you're satiated. So let's look at that. So these are brain reward activation systems. And one of the most important aspects of food is anticipation. When I see a food, the anticipation of reward from that food makes me have that behavior to go and eat. But when these people were given semaglutide, in this they gave a different drug, another GLP-1 agonist, but what they found is that the areas of the brain where there is reward center, they were less activated with the GLP-1 agonist compared to placebo. This is one area of the brain called orbitofrontal cortex. It also happened in the right and left putamen, where the GLP-1 agonist activated or reduced the anticipation of that food. So these areas were less activated compared to placebo. And it also happened in the left insula and the left amygdala, which are also responsible for providing us the drive and the desire to eat. So GLP-1 acted at several brain centers to reduce the anticipation of reward and reduce the behavior that would make you eat. So far we have looked at the fact that GLP-1 agonists, semaglutide, slow gastric emptying, have favorable effects on the pancreas, have favorable effect on our blood sugar regulation, on our lipoprotein profile or triglycerides, or fat and blood goes down. What we want to see is their actual impact on weight reduction. So this is a large study that was done. It's a phase 3 trial. That means it's a trial that they take to the FDA to say that this drug is safe and effective. Let's use it. And so in this study, what was found was that 1,300 patients in the semaglutide group, 600 patients in the placebo, younger group, predominantly female, about 80 pounds over their ideal body weight, BMI was 37. They were not diabetic, but about 45% of them were pre-diabetic. These were obese patients, not with diabetes. The reduction in weight loss was impressive. Semaglutide, 2.4 milligrams per week, dropped the weight by almost 17%, compared to placebo, which had roughly around a 2% weight drop. Over 90% of patients achieved more than 5% weight loss, 75, 10% weight loss. 55%, 15% weight loss, and about 35%, 20% weight loss. That is incredible. If you were 200 pounds, you would be down to 160 pounds. What did you have to pay for it? In order to get that benefit, what were the side effects? So what we found was that there was an impressive increase in nausea, vomiting, diarrhea, and constipation. This happened much more frequently. They defined it in a little funny way, number of events per 100-person year. So in 1 year, out of 100, how many people had that event? So fully 60% of these 100 people had nausea. 45% had diarrhea. Roughly 37% had vomiting. 23% had constipation, compared to much less numbers in the placebo group. There were also a few other things. Gallbladder disease was a little bit more common. Liver problems were a little bit more common. Gallstones was a little bit more common, but not by much. And pancreatitis, which is inflammation of the pancreas, occurred in 3 people compared to 0 in the placebo group. Were there other benefits? Let's take a look at that. Waist circumference decreased by an impressive, this is roughly, we are talking about 5 inches. Just imagine, 5 inches. Systolic blood pressure, your blood pressure got better. Your physical functioning score was better. You lost an impressive 38 pounds. 15.3 kilograms translates into 38 pounds. Now, this was accompanied by your triglycerides dropping and having less inflammation. So we've looked at semaglutide in patients with obesity. Now we're going to look at semaglutide in patients with type 2 diabetes. About 400 in the low dose group. So semaglutide used to be used at 1 milligram per week in diabetic patients, but these patients are not only diabetic, but they're obese. 55 years, 55% females, body mass index again about 75 pounds over their ideal body weight. They were quite diabetic because their A1C was 8.1. In this group, in terms of weight loss again, it was impressive at 68 weeks, roughly 10% in the high dose semaglutide and 7% in the 1 milligram group. The A1C at 68 weeks dropped from 8.1 to 6.4 in the semaglutide, 2.4, 6.6 in the other group, remained about the same in the placebo group. So diabetic improvement or diabetes improvement was robust. But you may be wondering, hey, how long do I have to take this drug? What would happen when I stop consuming this drug or when I stop injecting myself with this drug? So this is a study that looked at that. The drug was started at week 0 and continued for 20 weeks. This is called the run-in phase in about 800 patients. At the end of 20 weeks, about 535 the drug was continued and about 270 the drug was stopped. Again, these were young people, predominantly female. Let's see what happened. Semaglutide is started here. This is a 20-week run-in phase. At this point, 500 plus patients continue the drug, continue to have weight loss. These people stop using the drug and see what happens. Their weight loss is switched off and they regain roughly 70% of the weight that they had lost. So what that means is that in order to sustain weight loss, you perhaps have to continue using this drug. Now this is a unique study. It's usually not done in pharmaceutical industry. It's a study that's evaluating the effect of one drug versus the other in terms of weight loss in obese patients. So once daily injection of liraglutide, which is how it has to be injected because it's short acting, versus once weekly injection of semaglutide. Roughly about 250 patients, 125 in each group. And I said that these studies are really not done on a regular basis because one company does not like to go up against another company. But in this case, that was not a problem because Novo Nordisk, Joe Simmons is here from them. They make both the drugs, so they had nothing to lose. I mean, you would just change the income from one pocket to the other. It's going to the same company. And what happened is that the semaglutide had an impressively more weight reduction over the 68 weeks, roughly about 15.8% versus 6.4%. So it's more effective to use once weekly injection than once daily injection because the weight loss was much more impressive with the semaglutide group. Now, these drugs are injected. Now, this is a formulation of the drug that is oral. So in other words, there is now GLP-1 agonist that you can ingest by mouth. And a 50 milligram dose of that was compared with placebo in obese patients, roughly about 330 in each group. And what was found was, so the baseline characteristics in this group, the age was about 49, predominantly female, body mass index, again, impressive, about 80%, 80 pounds over their ideal body weight. The weight loss was impressive, 15.1% with the oral version of semaglutide versus 2.4%. The only problem is that I don't know how expensive it'll be, and it's not yet FDA approved. So you can't go up to Joe Simmons and say, hey, can I get this drug? A diabetic version of this drug called Rybelsus is available, but not for weight loss. And the diabetic version is in 4 and 14 milligrams, which is roughly about a magnitude less strong than the 50 milligram drug. So we talked about the side effects. The side effects of these drugs are nausea, vomiting, diarrhea. There's a small increase in pancreatitis, but really it's the gastrointestinal side effects. The other side effects are rare and less common, and their incidence is not that high. But before you start this drug, there are a few contraindications you got to know. One is that you can't start it in pregnancy. Two is that if you had medullary cancer of thyroid, it is contraindicated. And also if you have family history or personal history of a type of a cancer called MEN2 or multiple endocrine neoplasia. In addition, if you've had pancreatitis, you can't use this drug. So let's go through precautions. When you use this drug, you are improving your blood sugar control. So if you're also already on insulin, or if you are on oral hypoglycemics, you may need to reduce the dose. Otherwise, you're going to get hypoglycemic. So what I'm going to say is that talking about incretins that are a newer version of them, which is Mounjaro, which acts both through the GIP-1 and GLP-1 pathway. So this is a combined agonist of GIP and GLP-1, and it comes as Tirzepatide or Mounjaro. This drug was studied in a phase 3 trial, which means a trial that is taken to the FDA to approve the drug. It's done in large number of patients, a little over 600 in each group, 3 separate groups of Tirzepatide or Mounjaro and a placebo group. Younger people, 45, predominantly female, body mass index, again, very impressive, 37, so they were quite heavy. About 40% were pre-diabetic. The injection of Mounjaro is once a week. What is found again is that an even more impressive reduction in weight, 22% at the highest dose, 16% at the lowest dose compared to placebo. You can see here in graphic format. 20.9% at 15 milligrams, 19.5 at 10 milligrams, and 15% at 5 milligrams compared to placebo. The change in body weight from baseline to week 20, now this is just a trial when you evaluated at 20 weeks alone, just not even at 68 weeks, was 12.8 kilograms. There was an impressive reduction in blood pressure. Physical functioning was better. Triglycerides were roughly about 25% lower. The good cholesterol was about 8% higher. Insulin was reduced. So what did we find? Roughly a 28% drop in weight, quality of life better, drop in blood pressure, drop in triglycerides, improvement in HDL, and fasting insulin dropping. So these drugs have an impressive track record. They've been there around since 2005. And the reason I'm giving this presentation is because I'm willing to consider it in some of my patients who have evaluated and carefully counseled. But what are the concerns that I have? What is unknown about the long-term use of GLP-1 agonist? Perhaps the biggest in my mind is that whenever you use an agonist, like a GLP-1, it goes and binds to the receptor, the GLP-1 receptor, and it downregulates that receptor. It makes less of them available. You see that with opioids, in which the first dose of opioid has the maximum effect. Then as you continue using these opioid medications, and there is an opioid crisis in the country, the ongoing use of opioids is less effective because it downregulates the opioid receptors and makes pain management less effective. And what I want to know is that, is GLP-1 receptor downregulated? Is the downregulation temporary? When you stop it, can it regenerate? What time does it take to regenerate? Is it permanent? Now, these questions have not been investigated. So this is a schematic of receptor downregulation. GLP-1 agonist acting on GLP-1 receptor. That receptor is taken inside the cell by a specific process. It can either be recycled back to the membrane, or it can then be given to the garbage disposal mechanism of the body of the cell called lysosome and degraded, and less receptors will be available. This research is crucial, but I have not found a single paper that addresses this. So what are my final thoughts? I am optimistic about these drugs because these drugs have been around since 2005. We have nearly about a 20-year experience using them. We know for sure that they reduce appetite and hunger and improve satiety, that their weight loss is impressive, that it improves sugar and makes insulin work better. They reduce fat and blood or triglycerides and increase good cholesterol. They reduce inflammation. And many of my patients are struggling. Despite me counseling them, despite me being a preacher and telling them to do fasting, low-carb diet, exercise, sleep, they're not able to do that. They're not able to lose weight with lifestyle alone. But what are the issues with these that make me concerned? Number one is that they're expensive. If you don't have insurance or your insurance does not cover it, it's about roughly $12,000 to $15,000 a year. Maybe they are cheaper in Canada. You can ask Shanna. There are several of our patients who get these drugs from Canada. There is weight gain after you stop them. There is no research on GLP receptor downregulation. It causes nausea in over 50% of patients, vomiting in about 25% over 1 year of use. The pill form, although researched, is not yet available. And my fear is that may take away from the incentive to improve lifestyle in some patients. Thank you.